Welcome back. Today we're diving deep into the principles and management of dislocations, focusing on the highest yield concepts for your intermediate exams. First, definitions. A dislocation is the complete loss of contact between the articular surfaces of a joint. In contrast, a subluxation is a partial loss of contact. Distinguishing these is fundamental in clinical practice. Management is governed by the 6 R's. First, recognize the injury, and second, resuscitate if the patient has sustained polytrauma. Next, reduce the dislocation promptly and immediately reassess the neurovascular status. This is a critical step often tested. Finally, retain the reduction with appropriate splinting or bracing and begin to rehabilitate the joint to restore function. Your initial assessment must always include neurovascular status, associated fractures, and checking for open injuries or soft tissue damage. Investigations require X-rays before reduction. Standard views include AP and lateral, with oblique views if the diagnosis is unclear. There are absolute indications for emergency reduction without delay: vascular compromise, skin tenting, or an irreducible dislocation. Early complications can include neurovascular injury, compartment syndrome, or associated fractures. Watch for these in the acute phase. Late complications often involve joint stiffness, recurrent instability, osteoarthritis, or even a vascular necrosis. For the shoulder, 95% are anterior, usually caused by abduction, extension, and external rotation. Check the axillary nerve. Posterior shoulder dislocations are frequently missed. Remember the seizure trigger and look for the classic light bulb sign on X-ray. Elbow dislocations are usually posterior. Be vigilant about the brachial artery and the median and ulnar nerves during your assessment. 90% of hip dislocations are posterior, typically from dashboard injuries. The limb is held flexed, adducted, and internally rotated. A critical exam fact: you must reduce a hip dislocation within 6 hours to minimize the high risk of a vascular necrosis. Knee dislocations are orthopedic emergencies. Treat every case as a popliteal artery injury until proven otherwise. Check distal pulses and ABI. Patellar dislocations are usually lateral. For open dislocations, start IV antibiotics and proceed to urgent irrigation and debridement. To recap, shoulder is mostly anterior, hip is mostly posterior. Posterior shoulder equals seizures. Posterior hip equals flexion and adduction. Knee is vascular until proven otherwise. Always document neurovascular status before and after reduction, and post-reduction X-rays are mandatory. Mastering these high-yield concepts will serve you well in your intermediate exams. Stay clinical and good luck with your studies.